Welcome to today's webinar. My name is Becky Sanders. I am the Program Director for the Upper Midwest Telehealth Resource Center. And today we have with us Dr. Jonathan Neufeld. He's currently Director of the GP track, the Great Plains Telehealth Resource Center, but was instrumental in starting the Upper Midwest Telehealth Resource Center. So Jonathan, welcome back, and I'll let you take over.
All right, great. Thank you, Becky. Okay, so we are talking about telebehavioral health in rural health clinics, and I know there are more people here than just Indiana folks. I'm going to be focusing on Indiana just when it comes down to talking about Medicaid. Indiana has a couple of distinguishing features in the way it covers rural health clinics, but most of what I say will apply to those of you working in other states as well. And if you don't, you're in luck. If you don't know what the differences or the details are in your state, then you can, of course, contact your telehealth resource center. And that's what we do, is help people understand the relevant regulations and issues for each state in the country. So I'm going to talk a little bit about integration generally and some telehealth business models specifically that apply to rural health clinics, and then just some ways to go about getting to integration. If we have enough time, I might talk a little about technical issues, but I mean, there's stuff on technical, just introductory technical stuff at the end of this presentation, and if we don't get to it, that's fine. You can pull down the presentation. Becky, as Becky said, she can post it where you can get it, or she can send it out, and you can look at it, refer to that information there. It's UMTRC and GP Track are both part of a national consortium of telehealth resource centers. There are 14 of us across the country, 2 that focus on specific issues, policy, and technology, and then 12 of us that focus on geographic regions, sets of, or numbers of states. You can see there that UMTRC focuses on the orange states there, and then I'm right next door in the light green states. Well, it's got Heartland above it, but it says GP Track a little to the left there. Those are my states, basically Minnesota and everything it touches, including Nebraska, though it doesn't actually touch it, and not including Canada, of course. The National Telehealth Resource Center Consortium, the National Consortium, has a website at telehealthresourcecenters.org, and you can, at that site, find links to webinars and things that we do at the national level, as well as links to every regional and national telehealth resource center. Off to the right there, you can see each of the telehealth resource centers has a link and a logo, and so you are welcome to go through all of that material on all of their sites. We're not jealous about sharing business. We share all the time, and anybody anywhere is welcome to any of the materials that are on offer at any of those websites. In addition, what regional sites like UMTRC and GP Track provide are toolkits, assessment sample forms on our websites, as well as contacts with other organizations doing telehealth in your region and across the country. If you've heard of a telehealth program somewhere in the country, we can probably get a hold of them through one of our partners, and probably can get information or make contact if you want to bring them to a conference or ask a specific question or whatever. We also provide on-site training in various aspects of telehealth and help with evaluation and readiness and that sort of thing. So do please use those resources as you see fit. I probably don't have to tell this group much about how mental health care and primary care has grown over the last decade or two. When I got out of graduate school, I did a postdoc in integrated primary care, which at the time was a somewhat new idea, although it had been done for a long time, but it was becoming much more popular. Partly because of research that was starting to be done at that time, and has continued to be done, on just how much mental health comes up in the context of primary care. There are lots of mental health interventions in primary care, including prescription of medications and psychotherapy. In fact, more of that actually in primary care situations than in specialty mental health. And if you take all of healthcare combined, primary care providers prescribe 70% of psychotropic meds, which we've known for a while, and I haven't seen any shifts in that number, so I expect that it's going to stay high. And there are a number of other factors that contribute to the importance of mental health in primary care. I won't belabor them all, but one of the main things that I want to point out, especially to those who are operating in more rural settings or in more of a safety net sort of situation, is that on the upper right there, I say psychosocial distress drives utilization. That's something that is true even if there are not diagnosable mental health conditions. Whether a patient makes an appointment, comes to the doctor, is the largest driver of that, other than their physical condition, which obviously is a huge component as well. But in addition, why come this week instead of last week if I have a chronic condition, or why miss an appointment instead of make one, or what drives the overall level of engagement with healthcare? And a lot of that is psychosocial distress. So it makes sense to keep mental health folks close and keep them integrated, because they can provide a number of things in the primary care setting. First, of course, evidence-based treatments for mental health disorders. When a condition rises to the level of being diagnosable, then there are brief psychotherapeutic interventions that are effective for many health conditions. Combined medication and psychosocial intervention is often the gold standard. It's often the best treatment available for many mental health conditions. But then even when distress doesn't rise to the level of a diagnosable disorder, mental health clinicians can and do provide billable, reimbursable services in the primary care context to provide a brief supportive treatment of various kinds for patients facing various types of difficulties. As we know, life changes, things happen. A lot of our clients and patients live stressful lives, or lives that, for everybody, life changes and things come along that you're not expecting and that we have difficulty adjusting to. And so mental health folks can be very, very valuable in that situation, both as treatment providers, but also for the staff in the sense of a backstop or a buffer, sometimes I say, for the providers or the rest of the staff, just in being, providing a second perspective, providing supportive interaction. Mental health providers usually have more time. We schedule half hours or hours with patients instead of 10 and 15 minutes. And so sometimes the doctor gets what they need fairly quickly as far as information to provide a prescription or a treatment plan or whatever, but the patient still needs some time to kind of wind up or wind down from talking about their situation. And sometimes mental health providers can provide that extra time or extra space for patients to understand what the doctor's ordering, articulate their own concerns, work out a way that they're going to be able to follow through on appropriate treatment, all of those kinds of things which definitely impact both engagement and outcome. But sometimes the doctor just doesn't have time to do that as much as they would like to, as much as we all would like to see that all happen in the context of a primary care visit. And as much as primary care physicians are trained and qualified to do that sort of work, sometimes there are just time demands that are beyond that. Now, in addition to a rationale for providing behavioral health in primary care, I want to talk about telebehavioral health specifically. When we use telebehavioral health or telecommunications technology to integrate behavioral health into primary care, we can, at times, realize cost savings and improved efficiency of the overall system, as well as making it possible to have better access for patients and increased integration. Now, obviously, it's not automatic and doesn't happen just by itself, but there are opportunities to do that, to flexibility that telebehavioral health, that technology allows, to allow us to better utilize, more efficiently utilize the resources that we have. Mental health providers are in demand across the healthcare system. It's not just Indiana, or it's not just your state, wherever you are. It's all over. So we have to find ways to use the mental health providers that we have more efficiently. Not only that, organizations that adopt telehealth technology then have access to providers beyond their local service area. There are lots of providers and services out there that are willing to see your patients and work with your doctors, but they only can do it via video, live video. And so having telebehavioral health available makes that possible. Now, there are a range of services. I'm going to talk primarily about the kinds of things you would do in integrated primary care, but there are, of course, emergency mental health services that are often deployed in emergency departments or in inpatient units. You can get psychiatric diagnostics and medication management, psychological assessment and testing, and then also brief psychotherapy. You may not need the full range of those services, but certainly all of those are available. And I probably goes without saying, but the various licensure levels that you can engage, excuse me, will provide a different sort of type of services. Psychiatrists obviously are very expensive, but often, if your main concern is interfacing with local psychiatric hospitalization, a psychiatric hospital, or for inpatient admissions, or to provide that kind of liaison or better access to those inpatient resources to the extent that they're available. I know those are in high demand as well. Then a psychiatrist, or working with a psychiatrist, they can often provide that sort of direct integration that's necessary. Now, some states it's a little different. Certainly in Indiana, this is the case. Psychologists and counselors don't often, it varies again by state, but they aren't often able to provide direct admission or to streamline that interface with inpatient services, but they certainly can provide on-site services. Psychologists, of course, providing a little more in-depth testing, and the health and behavior codes, which I'll talk about a little bit later. Whereas counselors and master's level folks limited to psychotherapy codes, which again can provide a full range of services within their scope, but they're just certain codes that you can't bill for the LCSWs or master's level folks. I'm not going to talk about the 4-quadrant model. It's a fairly well-developed and popular model, but in my experience, really integration models boil down to a couple of different ways of thinking about it, and nothing against the 4-quadrant model, but basically for most organizations, we're talking about either having clinicians on site available and co-located, in the sense that they're able to work with doctors on site, which doesn't necessarily mean integrated. It means on site, but we'll talk about integration and co-location a little bit more. Or you have some sort of a partnership where you refer and see patients through referral and sort of reporting kind of relationships. And that can work well too, but presents its own set of challenges. And I'm going to focus primarily on co-located and integrated models, because really that's what telebehavioral health, that's what the use of technology can provide for us. Now, the Cherokee Health System folks from Tennessee, who have been doing this as long as anybody and are as successful at it as anybody, talk a lot about integration versus co-location, because co-location, being in the same place, does not automatically mean that you're integrated. What they mean by integration is that there are mental health folks on the team that the mental health folks get handoffs directly from primary care providers. They talk to providers a lot about what's going on with this patient. there are brief interventions as needed throughout the lifespan. It's not you refer to me, and I'll see a patient for 12 individual sessions, including 2 assessment sessions, and then when I'm done, I'll write a letter back to you. It's not like that. It's more constant communication, brief interventions on the order of 1 or 2, 5 sessions as needed, and continual updating, so that the mental health person is much more of a sort of an ancillary player and constantly available to the primary care provider. Co-located just means in the same place, and it could be integrated, but it more often means, patients are referred out, they get treatment, they're referred back. And frankly, most organizations are more comfortable, most primary care providers are more comfortable with that model, but it pays to dig into that a bit more and see if there aren't ways to make interactions more immediate, emphasize more verbal contact, meeting in the halls, talking about a patient you just saw, or talking about somebody you want to refer, introducing patients to providers. It enriches the clinical experience for the patient, and it improves effectiveness for the mental health provider, and can improve ultimately the skill set of the whole team. So it pays to be thinking along those lines. For a lot of folks, then, they end up aspiring to integration and ending up in what I call a middle model, which basically means there's a behavioral health consultant on site, that's your mental health non-physician available on site, or there is a psychiatrist available to consult, maybe see a few patients, or maybe talk to the primary care docs, sometimes both, but it's not quite full integration, it's not quite co-location. It's more a matter of, there are mental health resources available so that the doctors can call a psychiatrist if they have a question, or maybe a psychiatrist actually sits down with doctors by video or in person for an hour or 2 a week to talk about problem cases. And then there's a behavioral health consultant who's available to see patients on site or by video to provide the brief behavioral interventions that they can provide. And really, anymore, I've been doing this long enough that it's starting. Every situation, every system is kind of a mix and match kind of a thing. You take components and you put them together. Just like when, as Becky knows, I like to go to Dairy Queen. I like to have I like their blizzards, and they don't have a blizzard that has the things that I want in it. So I just tell them, put this, this, and this in it. That's my blizzard. And it's the same with, not quite, but it's similar in providing integrated telebehavioral health. If you've got access to psychiatry on site, well, then you use it. If you don't have it on site, then you figure out a way to bring it in by video for consultation. If you can bring it in by video to see patients directly, that's great too, because then those services are billable. But you basically use what you have and construct a service that works for your primary care docs, for your clinic, for the setting that you're in and the resources that you have access to. And if you need access to more services, well, then it's another thing that we try and do in the TRCs is make connections between organizations that want to provide services and organizations that need those services. The basic components of an integrated program, again, these vary a fair bit, but often there's a screening component where the doctor or the clinic will implement usually it's a quality improvement program of some kind where they want to screen everybody with a PHQ-2, PHQ-9 if they're more extensive. That's the patient health questionnaire. Talks primarily about depression, a little bit of anxiety, but it's a good indicator of just general distress. And giving every patient a PHQ-2 at every clinic appointment is not out of the question. It's quite possible that the person handing out paperwork at the front desk can just have, give a person that form as well. They can check a box off, or the medical assistant or nurse who rooms the patient can ask the 2 questions. It's very simple and very easy to do. Of course, once you screen, you have to have a follow-up and have something to provide. And so often a behavioral health consultant on site, or again by video, will be available to provide, a variety of sessions of various intensity. I say 2 to 6, but a lot, interestingly enough, a lot of clients need one session. They need a full hour to sit down, talk things through, to come to some kind of idea, some kind of resolution. Okay, here's a plan. Okay, great. And then you maybe don't see them again for 3 or 4 months. That one session is enough for them to kind of understand what the doctor's saying, express their own concerns about it, engage in a treatment plan, whether it involves a mental health component, or maybe it's just adjusting to being a diabetic, or what are my options for treating my heart disease, or why is the doctor always harping on me about this, that, and the other. Whatever their concern is, they get to address it, they can make a plan, and sometimes a single session is enough. So you have those brief interventions. Substance abuse is always something to be aware of and have some resources around. SBIRT is a standard sort of protocol for structured brief intervention and referral to treatment. So the provider, that's what SBIRT stands for. So either the doctor or the mental health folks can talk just briefly, do a brief little sort of quick introduction to substance abuse treatment and referral to local resources if the patient is unable or unwilling, or it's just not appropriate to engage them in the primary care setting for the substance abuse issue. Of course, this depends on your local resources as well. And then in most programs, there's also access to some sort of psychiatric consultation, whether that's, again, on-site, or somebody or a psychiatrist is actually seeing patients, or whether that psychiatrist is just providing consultation to primary care docs. And I'll say a little bit more on that in a minute. Often, too, the psychiatrist or psychiatric nurse practitioner that you're working with will have some ideas for medication guidelines or algorithms. And eventually, even if you don't start out this way, eventually your primary care docs will have sort of first line, second line things that they can try, if they don't already. A lot of times they do already, and then they'll develop that into sort of algorithms that they can use that can help them address the needs of more patients immediately in primary care before a referral goes out to a psychiatrist or a psychiatric nurse practitioner. So I got to talk a little bit about barriers. I've talked about the outlines of a program, the basic components, obviously the benefits or potential benefits. There are barriers that come up, and this is primarily from my experience. I'm sure many of you who have worked in this field understand there are other barriers as well, and you may have your own that you've come up against. But one of the things that has come up in my experience a fair bit is in working with a mental health provider, community mental health center, that wanted to make psychiatric resources available to local FQHCs and RHCs, local primary care clinics. And there was, from time to time, there's a disconnect between what each organization really wants out of that partnership, out of that arrangement. And the primary care docs were often thinking, oh, this will relieve me of some of my more difficult mental health patients. I'll get a back door into the mental health center, and I'll be able to send those patients there, and then they won't be troubling me in primary care where I can't really address their issues. And of course, the community mental health center didn't have any special access. The waiting lists are still the waiting lists. And so their kind of take on this was, we're going to provide better capacity. We're going to build greater capacity in primary care to manage those patients. And that disconnect didn't always, it led to some challenges moving forward as to what exactly is the goal here when a primary care doc identifies a patient that needs mental health intervention of some kind. It very quickly is a patient they're uncomfortable with and they'd love to refer, but the psychiatrist is saying, well, this is not that difficult a patient. It's certainly not, as difficult as most of the patients we deal with at the community mental health center. This is probably something we can manage in primary care. And so building a relationship that becomes a powerful, effective working relationship between those two sets of clinicians is a challenge. It definitely is a challenge. Sometimes either provider is adjusting to roles that are unfamiliar. The PCPs often will refer poorly fitting patients, like only suicidal patients. That's the time that I refer. Well, if a person's acutely suicidal, a referral to mental health or calling the psychiatrist is not going to fix that problem. You need on-site procedures to deal with suicidal patients. Every clinic has those kinds of procedures, and calling the psychiatrist or behavioral health clinician in that case is not. It helps to manage the situation, but that's not really the best use, making the best use of that resource. Sometimes PCPs I have found that they've been reluctant to refer to behavioral health clinicians, or the clinicians themselves have just not really adjusted well to the pace of primary care, or been able to become effective in a brief format, because it's not, a scheduled hour of psychotherapy. It is a much more fast-paced, brief interventions. See you a couple of times. Okay, you're better. All right. See you whenever you need to come back. The patient kind of decides when they're ready to come back. It's a much more flexible sort of engagement, and some clinicians struggle with that. All right, so let's talk about billing. These are not rows on a table. These are actually separate columns, and the only point of this slide is to make the point that lots of different types of facilities and providers can bill for telehealth services. Lots of payers, all payers, pay for those services to some degree. There are some caveats or specifics that we'll talk about, and then just about any kind of service that they provide, other than injections and adjustments and procedures that need hands-on touch. Lots of interventions can be paid for and provided by telehealth. So let's talk about Medicare first. Medicare is, on one hand, the most frustrating. On the other hand, the most straightforward. They print a 6-page document just about every year that says, here's how you do telemedicine within Medicare. And it's pretty straightforward. You read through that and it tells you everything you need to know. Unfortunately, the coverage for Medicare is not, it has one specific caveat that's a big challenge, and that's the rural originating site. You can think about telehealth as a carve-out service, in the sense that it doesn't interact with any other services in Medicare. When you're providing telehealth services, Medicare sees it as a separate thing. You've got a rural patient, you've got a provider at a distance to that patient. You got two separate facilities, and Medicare is willing to pay the doctor in their regular rate in order to see the patient in some rural facility, and then pay the patient facility fee. And that's the way Medicare sees it, and it's separate from just about everything else they do. They list all of their codes. This is a link to that document. If you need a copy of that document, you can also get the document at either UMTRC's website or GPTRAC's website. Medicare pays for this list of clinicians: physicians, nurse practitioners, psychologists, social workers, registered dietitians. That brochure lists, this is just a partial list, but it lists all the CPT codes that Medicare will pay for. And I just circle those mental health codes because anyone who takes a quick look at that, and if you know mental health billing, you can see that the bread and butter of mental health care is right there. There's just nothing, there's very few codes that you will regularly provide in a mental health service that aren't in that list. So your health and behavior codes for clinical psychologists, all of your mental health codes for psychiatrists and psychologists and clinical social workers are in there, psychotherapy codes. Group codes are not. A couple of just sort of more obscure codes are not, but again, the meat and potatoes of what you do is in there. Now, Medicare's primary limitation, as I said before, the clinic, Medicare doesn't pay for any services to the home. So if you're thinking of going into a patient's home, Medicare is not going to go there. The patient has to be in an office or a hospital or a clinic or some sort of medical facility. It's a wide range of medical facilities that they'll cover, but it's not the home. And that facility has to be in a non-metropolitan statistical area. And it goes down, it used to be the county, now they go down even further to the census tract. And because it's a little complicated to understand the rule, they've made a tool. This is a link to that tool, and you can find out, exactly, put in your address, the address of your originating site, and find out, go to this link, put in the address of your originating site, and find out whether Medicare will pay for a telemedicine encounter that originates from that address. The second limitation that I always bring up, it's a little bit, it's maybe a little more detail than you care to know, but Medicare and CMS assumes, when we're talking about telehealth, that the patient site, which they call the originating site, and the clinician site, which they call the distant site, are two separate entities. They bill separately. The clinician can bill for their pro fee. The patient site can bill for an originating site fee, which is also a Part B payment. It's not a facility fee like hospitals. It's an outpatient facility fee. Those two organizations can bill for those two charges separately. They're separate entities. Of course, challenges arise when, I'm going into Medicaid here. Challenges arise when when a clinic contracts with a provider, and then the provider turns over billing to the clinic. And if that provider is at a distant location, they basically telecommute into the clinic to see patients. This is actually a thing in Indiana. They call it telecommuting. The provider can telecommute into the clinic and see patients in the clinic. That sort of an arrangement, Medicare at the federal level just doesn't recognize, doesn't understand. Now, Indiana Medicaid does well with it, does very well with it. And some of your states also have regulations around that. Not very many. I know that Illinois does, but not many others. California does, but I don't know if there's anyone here from California, but there are very few that recognize that arrangement. Although I have to say, many RHCs and F2HCs use that billing arrangement and are functioning, providing telehealth, telebehavioral health services under that sort of an arrangement. It's just that federal CMS just doesn't have a valid definition for it at this point. They're working on it, but they don't have a valid definition at this point. The one exception, I guess, is if you're a next-gen ACO, then you've got free reign to use telehealth as you see fit, which is a Medicare program. But outside that framework, and a couple of other ACO models have somewhat expanded the use of telehealth. But outside that framework, in a strictly fee-for-service Medicare arrangement, CMS doesn't recognize the model. But like I say, they do get billed according to that model, and they do pay according to that model. There's no problem getting paid, but we haven't seen a lot of haven't seen any justification or verification that payment is valid and would not be subject to post-payment review. So in Indiana, I'm just listing some of the regulations, but in short, Indiana Medicaid pays for telemedicine, has for a long time. The code has been updated, or the policy has been updated a number of times. What it doesn't pay for is the use of a telephone or email or fax machine, which most telemedicine definitions don't include. And they don't pay for trans-telephonic monitoring, which is basically using a phone line as a data line to send data, or for consultation between doctors. Okay, so telemedicine is none of those things. Indiana Medicaid pays for telemedicine, but telemedicine is not those things. IHCP, the Indiana Health Coverage Programs, like I said, pay for telemedicine. You can get all the bulletins and updates there. You can also get it on our website. Oh, this is the first crappy looking slide. And it's important. Okay, so I'll try and, you can sort this out later using your decoder ring. But what this says is that, and I've mentioned this a little bit before, for Indiana Medicaid and for most Medicaid, I've not seen a Medicaid that has the same rural-urban distinction that Medicare says. So almost all Medicaid policies ignore rural urban location for the patient. But some of them do have other little distance requirements and such. Indiana doesn't anymore. But where there is a challenge is that assignment of billing is not prohibited, of course, but at the federal level, RHCs and community health centers or FQHCs cannot be the distant or the billing site for Medicare. It's just a quirk of the Medicare billing that Medicare doesn't want to see an FQHC or an RHC bill for telemedicine, bill a pro fee for a telemedicine service. Now, Indiana Medicaid, not Medicare, Medicaid does allow RHCs and FQHCs to bill their regular PPS rate for a telemedicine encounter when it's conducted on-site by clinicians that they're contracted with. Okay, so this is exactly what we were talking about. You can contract with a provider, say it's a psychiatrist or remote psychiatrist. They can virtually enter your clinic and see your patients and turn over their billing to you, and you, the RHC or the FQHC, can bill your PPS rate for those encounters. In Indiana and Illinois, I know that's true, and in California. If you're not in those states, then check with your local TRC. But so that's available for Medicaid, but not for Medicare. Medicare doesn't recognize that arrangement. Now, for RHCs, we've got a cute little workaround here. If you're connected with a critical access hospital, then they can bill those pro fees from Medicare. So if you're either a provider-based clinic or have an arrangement or a relationship with with the critical access hospital, then the provider can be contracted through them and then billed through them for Medicare in those cases. As far as commercial providers go, again, I'm focusing on Indiana here. Indiana has telehealth parity, 26 to 30, somewhere in that range of states. Might even be more than that by now, but most states have similar parity legislation so that commercial payers are required to cover telemedicine just like they would cover an in-person visit. Now, there are developments along these lines, it seems like every day, every week, where a payer will decide, well, we're going to contract for telemedicine services, so that gets us out of this requirement, or we're going to do ours a certain way, and so we're meeting the letter of the law, but not the spirit. There's still problems with getting commercial payers to pay for telemedicine, but that's nothing new. I mean, you get denials every now and then, inappropriate denials every now and then. You have to work those claims to get them paid for. So if you're working with commercial payers, it can be a challenge, of course, but it is possible to get that paid for. And in any state with a parity law, there is regulatory language that mandates that payment. Another thing to recognize, and I just kind of threw this in here because I talked about it earlier, and I want to just emphasize again, the real absolute betterness, the superiority of a model where the behavioral health consultant and the primary care provider are working in the same medical record. So this, whether they're co-located or one or another mental health clinician, psychiatrist, or consultant is coming in from off-site, when they're working in the same record, and that would imply that that clinician is contracted or hired by the clinic, would imply that that they've turned over billing to the clinic, so that then they're a credentialed provider at the clinic and they sign into the EMR when they see patients and they make their notes in there. That is just by far the preferred way of functioning because it allows a much greater range of integration, much greater level of integration on a session by session, appointment by appointment basis. Even when the consultant can't be on site, which was implied by the use of telehealth, at least their notes can be in the chart and the primary care doc can see those notes, can message the provider, the consultant about the patient if they want to do that. There are just a lot more opportunities for interacting the same way they would interact with any other member of the staff. So it's definitely a preferred way to function. So let's talk a little about policies and procedures. If you're using telehealth, you will need to mention that, of course, and include that in your policies and procedures. But it's becoming more and more best practice to keep those P and Ps generic and minimal, in the sense that telehealth is not a separate thing that you do. It's another way of doing the same thing that you do. And that's an important distinction to make. When a patient is being seen by telehealth, do they need different informed consent? Do they need to see a different clinician, or use a different nurse, or a different room, or whatever? You try and minimize the difference as much as possible, so that when a patient comes in to see a provider via telehealth, that the check-in procedure is the same. The waiting room procedure, the rooming procedure, all of that is as much as possible the same, so that you have your policies don't have to be, so that people don't have to learn a second set of procedures, that they don't have to do a whole lot of things different, but they can do mostly the same thing. The only difference being that the doctor is entering the room on a video cart, or on a video screen on the wall, or coming in electronically. Now, granted, when it gets down to the details, it is a very different sort of a thing. It's a different kind of an encounter. But I just want to underscore, as you're working on those policies and procedures, that you try and maintain similarity as much as possible, and recognize that telehealth is not that different than what you're doing otherwise. And again, when you contact us, follow up with the TRCs, we can walk you through that and talk you through how that is the case, and how to mirror that, reflect that in your policies. The other thing that is important is there's an alternative procedures kind of section, or what to do if the encounter can't be completed, because very rarely are you going to have a clinician, an on-site doctor, a clinician, who can't complete an encounter because they faint, or they have a stroke right there in their own clinic. It's just rare that would happen. However, there is a possibility, and you have to be aware of this, that there might be technical issues or other issues that prevent a telehealth encounter from being completed. And so you need to have procedures in place for an encounter that cannot be completed, either due to a power outage, network failure, technical issue, or if the provider at the distant site just decides that, telehealth is not going to cut it for this encounter. I can't see the patient well enough. I can't hear the patient well enough. I'm not getting enough information to make a good diagnosis. The connection is bad. The patient's in a crisis. This is not appropriate to see them. They need some on-site physical intervention of some kind. If they threaten suicide, then it's just not, you can't do that over telehealth. And so you need a way to say, okay, we can't complete this encounter as planned. We're going to plan B. And you need a plan B procedure, which is pretty generic, because you already have plan B procedures for patients that threaten suicide in the clinic, right? I mean, or a patient who, faints or goes into some sort of medical emergency in the clinic, you have procedures already in place for that. And those are the procedures that you engage when a telehealth encounter can't be completed. Now, you might want to add a very mild one, like there was just a technical difficulty, and so what we did is we rebooted the machine and tried again. It didn't work. So because we were, most of the way through the encounter, we went ahead and did a phone call, and they completed the encounter by phone. That's a perfectly legitimate alternative procedure for a technical issue. If the technical issue comes earlier in the encounter and the doctor says, I really don't have enough information to complete this, then we reschedule for another time. And the patient was fine with that and left with instructions to come back, whatever. Those are perfectly legitimate alternative procedures for a failed encounter. When, of course, if it's a medical or psychiatric emergency, well, then you would immediately have an established way for the remote clinician to be able to call or contact somebody who's on site, where they will not give voicemail. It's a hotline, a backline, where they call in, the phone will be picked up, and somebody can get into that room and intervene with that patient if there's some sort of a psychiatric or medical crisis. And so that's definitely part of your policies and procedures. But then at that point, the remote clinician turns over care to the local site, and the local site follows up from there. Do we need to call local law enforcement? Do we need to call an ambulance? Do we need to, get to instruct the patient to go directly to the emergency room? Whatever kinds of procedures you normally have, those are what you engage at that point. Okay, so we got a few more minutes. I'll just talk about a couple of technical things just to kind of introduce folks who haven't been down this road. This information is getting older and older, but the basic idea is still the same. We used to pay, well, you can still pay $10,000, $20,000, $50,000 for a full telemedicine cart. If you're only doing live video, there are lots of cheaper ways to do it. We started at UMTRC with building these $5,000 endpoints, and pretty quickly we went to a web-based system that cost about $1,200 and was just used a fairly generic commodity computer and screen with webcam and speaker and some very nice software, and a very nice software package, just like what we're using today, that does an excellent job of providing high quality video and audio. And that little cart that could roll around in the clinic was all we needed for a lot of the interventions. You can even do the same thing with a laptop or a desktop computer, if you've got those pieces of equipment already lying around somewhere. It does not take a high-powered computer. What it does take is a good quality internet connection. If any of you are having trouble hearing my audio or seeing the video, or it's choppy or whatever, then you don't have a good enough connection to do telemedicine in general. I mean, it may be just some kind of temporary thing, but basically what I tell organizations, if you can stream a Netflix high definition movie, then you can do telemedicine. It's not, you don't need anything exotic, you just need high quality bandwidth. But it's not anymore, it's not exotic. Now I know there are rural areas where you still can't even get good broadband, but there are more and more options out there. And really don't kid yourself, broadband is the foundation. I mean, that's the boat, that's the water. The broadband is the water under your boat. No matter how nice a boat you've got, it's got to have water. And without the water, your nice boat is just a weird shaped extra room. So you got to have good broadband to make it work. Peripherals, you can plug peripherals into generic equipment like we've just shown. You can also plug it into more expensive equipment. What the more expensive all-in-one units do often is integrate those peripherals such that, they've got a nice on-screen display. You can bring up the derm cam, and then the derm cam is live, or bring up the stethoscope, and the stethoscope is live. Whereas with a computer-based, generic computer-based system, it'll take a little more tweaking, and the nurse might have to adjust some things, and it won't be quite as slick. Some of you may have full-blown EMRs that incorporate live video, that incorporate peripheral devices like this too, and that again makes it convenient and straightforward to operate them. But the point here is that peripherals that can provide any sort of physiological data that you need, many kinds of physiological data, let me say, are available out there. This is a very common Bluetooth stethoscope used all over. Otoscopes, various cost ranges that can be used to provide, a picture. Obviously, the thing to remember when you're using a peripheral of any kind, well, that means you're going to need somebody on site to operate the peripheral. We don't want the patient just, moving it themselves or, sticking something in their ear, obviously. So you're going to need on-site staff to do that, just like you would to do that, to operate a peripheral now. And so here's where I say that you got to have a local operator or presenter for peripheral use. Training, it's not absolutely necessary, but it is certainly a good idea to at least provide some justification that you're on-site folks are competent to present a patient and use the various tools that they need to use. Now, often a doctor and a staff, and chief of nursing or whatever, people get together and say, okay, is this how it works? Okay, this is how it works. Okay, we're good. And that's what training is. And obviously that can suffice in many situations, but it's also important to think about getting folks a higher degree of training, some sort of certification, especially if you're working with commercial payers, because they're going to want to see that often. And it is part of your obligation under whatever sort of credentialing you have for your organization. So, and it also helps to have your clinicians be more comfortable and feel like they know what they're doing and they're not missing anything. All right, so that's a little bit about technology here. I included some links to some of the resources you can follow up on. The Center for Integrated Health Solutions at SAMHSA is an excellent set of resources, a lot of resources there. The UMTRC is, of course, an outstanding resource, and then the National Consortium link there. Here's my contact information, and I'll leave that up for a little while. Just so you can copy that down. Obviously, you can get it off the slides if you get those. And with that, I will turn it back over to you, Becky. Do you want me to stop the share?
Yeah, go ahead and stop the share. So thank you all for joining us today. Here's the portion where we open up for questions, and you should have that icon for Q&A. This is the time to ask those questions, and we'll try and answer as many as we can. We do have the ability to record those questions. You've got Jonathan's contact information. Certainly we can follow up later if we can't answer questions on the line right now. And also, while you're thinking of questions, I am going to use the chat function, and I am going to send you a quick survey. It's just a couple of questions, and please go ahead and complete that survey for us as we continue to fill out our 2018 calendar for our UMTRC webinars. All right, here we go. What about virtual groups? Are you doing them, and is it a billable service?
Virtual groups. So there's several layers to talk about here. One is whether they're being paid. I have done them in the past. I'm not doing them now. Whether they're being paid. Medicare doesn't include a group code in its billable codes. Indiana Medicaid doesn't include the code. I'm not sure if they would pay it. I don't know if there would be issues or not with paying it, and then commercial payers are going to be, if it's a covered service, then parity would technically say if it's covered in person, then they should cover it virtually. The trouble with groups is that they are a challenge, both technically and clinically, to do well. Part of the issue is that, the main issue is that it depends, who's remote and who's on site. If you were, 8 people all coming in by video and doing a group that way, that actually would probably be preferred. Now, it's very different than classic group therapy that I was trained in and many clinicians were trained in. But it is possible to do that. It's also possible to use a format like that for something like group psychoeducation, where it's primarily, a light lecture with Q&A, or if you're doing other types of things that you would do in a group, where it's primarily information that you're sending and getting some feedback. That's more, telehealth is a little more amenable to that if you can get it paid for. But there are the standard dynamics of group therapy are very hard to recreate virtually, especially if it's the clinician who's coming in. I saw a family once, and basically just had to seat them like a choir, 2 rows in front of the camera of, 3 people in the front and 2 in the back. And the kind of interpersonal dynamics that you would expect to develop in that situation are not the same as if you can spread those people around a room and choose your seating position and choose how you direct the conversation. So it's a challenge to do kind of full-blown standard group therapy, but there are many kind of group psychoeducational things that you could do over video. But it will be a challenge to get them paid for, because it's rare that it's a covered benefit in any of these plans.
Mm-hmm. All right, what other questions? I did get a question about, oh, here we go. There's another one. What pitfalls do you see with EMR integration?
EMR integration. Well, I'm assuming by that you mean using, when an EMR, many of the major EMRs include a live video component. And so you can use the live video functionality within the EMR to do the encounter. I don't know that adds any sort of problems that you wouldn't have to address using a third-party video tool. The main, I mean, obviously you're dependent on the EMRs, on the quality of the EMR integration. I mean, if they implement it badly, then it might be hard to use. But that's sort of, I mean, that's an issue when you have an EMR. You're sort of subject to their implementation and the quality of it. I don't see a whole lot of drawbacks beyond that. Cost may be an issue. I don't know. Various EMRs are going to integrate that functionality for different costs, and you certainly have some very low cost options when you're using third-party software. Excuse me. But I don't see a lot of drawbacks to it. In fact, I've heard Stuart Ferguson from Alaska Native Tribal Health Consortium and former president of ATA, he really thinks that telehealth platforms per se are going to go away, and eventually we'll be doing all telehealth within the EMR. So it's quite possible that that's going to increase, and the EMR vendors are going to get good at it, and that's going to squeeze out a lot of the standalone telehealth platform providers.
Mm-hmm. Clarification on that last question. So between the mental health provider and the PCP, how does that, in a truly integrated situation with the EMR?
Well, that's going to vary. Any of you who have worked in more than one EMR recognize too that EMRs are different, and it's going to vary with implementation. And even if you work in two different instances of Epic, for example, different implementations of Epic vary. It would be great if a remote clinician could, provide video to a client through the embedded video in the EMR, and then also after the session, maybe ping the provider, or provider could ping one way or the other, and the primary care doc and the clinician could check in on the patient, or even see the patient together. I mean, there should be ways to do that. It's just going to depend on the EMR implementation and how it's set up within the EMR. I think it's a great possibility, and I haven't seen it done that way. And frankly, I think the challenges are going to be more organizational and implementation rather than technical. The EMRs can do it once they decide to, and once they decide that there's value to it. The EMR companies can do it. Whether or not any particular EMR can or can't, I don't know. You'd have to see. But I think the challenges that we find most often is, getting an organization to adopt procedures that will support that sort of interaction and integration. That's the hard part.
Yeah. All right. I did get. Here's another one. I would say that I did get a question about the slides, and I'm going to put my email in the chat. I will try and send out the slides to everyone. If Jonathan, if you'll send those to me, and any other requests you can send to me directly as well. Oh, you know what? That's not my right email. I'm trying to talk and do too many things at once. bsanders@Indiana. So use that second email address if you want to email me. Can behavioral health be done across state lines? Another great question.
Well, sure it can. You can also you lose your license doing it. So I should have covered this. This is like basic level kind of stuff. You as a licensed clinician, your license has boundaries. So you can, like, I'm licensed in Indiana and a couple other states, which means that I can see patients as long as the patient is in Indiana at the time. The license covers the location of the patient. Health services exist at the patient's location. So it doesn't matter where I am as a provider. I could be anywhere in the country or anywhere in the world. If the patient is in Indiana, then I am practicing clinical psychology in Indiana, and I need to be appropriately licensed to do that. If the patient is in a different state, then I need to get a license for that state. Now, so the services can be provided across state lines, but the provider has to be licensed at the patient's location. So that's the caveat there. Most telehealth organizations, telehealth service providers, telepsychiatry groups, or telemental health groups, if they're looking to contract with you to provide psychiatry hours or mental health hours, they know about getting licenses, and it's part of their job to go out and get those licenses for all of their people to make sure that they're licensed in whatever state they want to do a contract in. So they're well aware of that. But yeah, that is the basic requirement, that you have to be licensed at the patient's location.
Mm-hmm. Yeah, so to follow up to that, what about a student who goes to college out of state?
Yeah, most of the time what happens is that sort of thing gets covered by licensure laws or policies that sort of talk about intermittent or emergency or temporary arrangements, like when somebody's traveling and they call their doctor and say, "Oh my goodness, that sore throat I told you about, it flared up again. Can you prescribe some more of that same medicine?" And the doctor says, "Sure, I'll send. Where's your pharmacy?" And so basically that's covered. I mean, technically you're practicing medicine across a state line when you do that if the patient is out of state, but that's covered with sort of temporary short-term arrangement rules. Now, if it's mental health, often, and if a patient is going to college somewhere, then they're out of state for a longer term than 1 or 2 sessions, and that's going to be something that you'll want to check with your medical board on. And in fact, it's going to be something that you'll want to check with the other state's medical or psychological board. Whatever your licensing board is, you're going to check with the other state to say, "Look, hey, I'm licensed here. My client is going to college there in your state. What are your policies on me seeing them by video in your state?" And I can tell you most licensure boards are going to be very conservative about that. They're going to say no first, and you're going to have to argue for a special arrangement to be able to do that. Some states will have streamlined licensure application, or they'll do some sort of special agreement with you. But yeah, if we're talking about more than a session or 2, you're really practicing across state lines in the eyes of the licensure board, and you should check with them and see what their policy is going to be on that.
All right. I don't have any other questions in the Q&A. This is last call for questions. I will say I have heard of people who have students that are in a behavioral health relationship, and the student has actually driven back across a state line to be in a state where the provider is actually licensed. But that would only work for like a private payer. It wouldn't work for a Medicare or a Medicaid where the patient has to be in a clinical site.
Right. Right. You're also talking about going to the patient's home or originating from the patient's home, and the payer might have policies on that as well, or residents wherever they are.
Right. All right. Well, I don't see any further questions, Jonathan. Thank you so much for your time today. I really appreciate it. I always learn more little nuggets here and there too. So. All right. Well, thanks everyone, and we'll get the record. I'm going to go ahead and stop the recording.